Good morning, everyone, and welcome to today's call entitled Facing the Challenges of Oral Health Care for Seniors. My name is Deborah Schmidt. I'm the Member Services Manager for the National Network for Oral Health Access, or NOAA, and I'm today's moderator. I am also joined today by NOAA Education Director, Candace Owen. Now, the learning objectives for today's call will be, number one, review the dental demographics of the senior population in the United States, describe current trends in oral health in older adults, describe functional status and oral health in aging, and lastly, listing the 10 most common oral health concerns of the elder population. Before we get started, let me go over a couple of housekeeping items. Your phones are on mute today, but you can submit your questions in the question box at any time during the presentation. Your questions will be asked of the presenter, Dr. Brennan, at the end of his slides. This call also is being recorded, so we have included a copy of the PowerPoint presentation as a handout. You should see that option on your screen. A short survey will also be emailed to you at the end of today's call, so you can provide feedback as well as to request continuing dental education credits. You must complete the survey by close of business Friday, April 3rd, if you would like to receive the CBE. Let me introduce today's speaker. Dr. Leonard Brennan is co-director of the Harvard School of Dental Medicine's Geriatric Fellowship Program and a clinical instructor in their Department of Oral Health Policy and Epidemiology. Dr. Brennan has practiced general dentistry in Portland, Oregon for more than 30 years. He is also the guest editor for the Dental Clinics of North America's Dental Geriatric Edition and the author of the chapter, Cognitive Impairment in Older Adults. He also has extensive experience developing team-based approaches to multidisciplinary teams caring for the elderly and underserved in rural areas. Let me now turn the presentation over to Dr. Brennan.
Thank you. I am from Portland, Maine. I'm on the other coast. And I want to thank Candace Owen and also Dr. Christine Reedy, who is the chair of our oral health policy and epidemiology at Harvard, just for having the opportunity to be involved in this seminar. Oral health for seniors has been a passion of mine for 39 years. And I had the pleasure last year of attending the NOAA meeting in San Diego, and it was a great conference. I had a chance to meet many individuals that were working to improve oral health to the underserved, similar to what I do. And some of those individuals was Candace and also Dr. Steve Kierman, Steve Grover, and many members of the West Foundation. So my journey in geriatrics began 39 years ago. I could see this wave of seniors flooding our healthcare system. In 1991, NOAA was one of the very first groups that I saw step forward to be champions for this underserved population with their integrated model of care, and it's proved to be very successful. So part of our conversation today will be looking at senior demographics and trends and try to relate them to how it would improve your practices and how you look at the aged. For example, when we look at seniors, they're a very intricate and complicated and multi-layered group of individuals. When we look at them as a group, we may look at them as individuals with gray hair and wrinkles, similar body shapes and cardigan sweaters. But physiologically, every senior is very, very different. If you look at a group of 20-year-olds at a rock concert, they can look very different with hairstyles and rings and clothing and dyes, but physiologically, 20-year-olds are very similar. So part of what we're doing today is looking at some of those differences and how it affects our practices. Personally, I sincerely believe in the mission of NOAA to improve the oral health for the underserved population. It's like kindred. It's something that I believe in completely. And NOAA's values of oral health integration is very important to me. That it's evidence-based and it's collaborative is really the foundation for me and in my journey of helping seniors in their oral health. So if we go to Now, I'm not, my slide is not advancing, Candace. So could you advance that for me? Candace, could you advance my slide, or is that stuck? Oh, okay, great. Thank you. The objectives that I want to talk about today are the demographics and current trends, and I want to look at this as more of a visual instead of looking at statistics, something that you can visualize and picture and look at from 30,000 feet, and not to get involved so much in the numbers. First, what I want to take a look at is the number one question that I get asked is, how long have I been involved with seniors? It's been 39 years. And then the other most common question I get is, why are you doing it? So I want to tell you a story about my very first week of practice in Portland, Maine. One of my very first patients was a woman named Millie, who had come in to interview me as her new dentist. And I was only 28 years old. Well, after a long discussion of my philosophies and treatment strategies, she asked me this million-dollar question. When I'm 85, are you going to still manage my health care? You know, I was young and naive. I hadn't thought about that. And I answered, absolutely, I will. But I have to tell you, over the course of 39 years, I have learned what Noah has learned, that there are barriers. It's important to develop partnerships. We need to create access points, and we need to work through interdisciplinary teams. So when I go through these objectives today, I actually want to go through these objectives through the eyes of 4 of my favorite patients: Millie, Rose, Walter, and Joe, and you'll be introduced to all of them. Listed here are 4 statements that I hear the most frequent from my community, and I suspect you might, and also from my medical and dental colleagues. The first is that oral disease is just a part of growing older. And it's such a myth, but many people, I'm not advancing again. Could you advance that again for me, Candace? There we go. We are not pre-programmed to develop oral disease like we do wrinkles and gray hair and sore joints. The reason this statement is so very, very important, that if we believe that oral disease is a normal part of aging, we treat that as such, and our health policies for seniors grow out of the fact that, you know, we don't treat wrinkles and we don't treat gray hair. Why should we treat oral disease? So I think this is a very important myth that we have to deal with. The second, dry mouth is a normal part of the aging process. We just have to live with it. This is a very important myth that I think that we have to share with the dental community and the medical community and any healthcare providers. Most dryness occurs through medications and disease. And if we remember that 4 or 5 of the top 400 to 500 of the top drugs that we prescribe seniors cause dry mouth and taste disturbances, and that these drugs will drastically affect oral disease. Many times when I'm talking to my colleagues and they want to know specific drugs in specifics, I will generally say, just assume that if they're taking medication, most likely it's causing dry mouth. And what you want to do is to deal as a team with the effects of that dry mouth. The third statement, oral health education is integrated into other health disciplines. I have not seen as much as I would like over the course of 40 years. I think we're lacking severely on this. But I hear it frequently from the public, because the public believes because we have this wave of seniors entering our healthcare system, we must be ready for them, and we must be trained for them. And I think the reverse is true. The fourth statement, oral health care for seniors has steadily improved, similar to that of children. Is really, it's a myth. And one of the lectures that I attended at the convention in San Diego, the ADA chief economist, Marco Vachusik, told the story of the gap that's increasing between those that have and those that have not. And we'll address this later as we kind of go through the lecture. The fifth myth that I want to just talk about, and in some ways maybe it was my biggest shock, was that when I talk in terms of at dental societies and state boards around New England, around the United States, I hear this as frequently as I hear any other type of myth from board members and from dental members, that one of the problems facing residents in care facilities is that the staff does not wish to provide oral care for seniors, because we all know that only dentists want to look into someone's mouth. The number one question that I get from CNAs, the number one question is, how can I take care of my resident's mouth? I want to do that. So it's a fallacy that I think that we have to go back and to re-educate our own profession, that we have other team members, and we're not the only team member that can be involved in oral health care. So when we look at the dental demographics, and I want to look at three parts of this demographic. One is the wave population, and I want to look at it from a distance so we can kind of see what this wave means. Then I want to kind of go into the wave and look at the state of oral health of the older Americans in this wave. And I also want to talk a little bit about this gap that's getting larger between the haves and the have-nots. And my goal is not to give you lots of statistics. It's really to look at the picture of this. But as we go through the demographics, just as a general rule, I think that we can safely say that across the board, finances, age, race, and socio-demographics really determine the extent of need. If we're older, poorer, Black, Native American, you suffer the most. You have fewer teeth, you have poorer gums, you'll have more decay, you'll have more pain, and you'll have a lower quality of life. So this is the wave. And I don't want to get into the statistics, but you can see it kind of looks like a wave or a tsunami of the population that's increasing. But I want to take a look at 2 points on this. If you've got 1950, that 11 means that there were approximately 11 million seniors in 1950 out of a population of about 160 million. It's not necessarily remember those numbers, but what I want you to visualize is if you're in a community center room and there's 100 people in that room in 1950, and you don't want to, if you step into that room and you look around, 4 or 5 people out of that 100 will be seniors. And now if we move forward to 2050, and we see that there's 88, that's 88 at the top, that market, 88 million seniors out of a population of 430 million-ish. When we go into that same community room and that we look around, you're going to be elbow to elbow with other seniors, because 1 out of 5 will be older. So the first layer that we sort of looked at when we were looking at seniors is that they physiologically they're different. So let's peel off that first layer and look at another layer of a senior. And out of the population in 2013, and again, the numbers aren't that important, but it is important to look at that up to 30% of these seniors in the United States have some type of cognitive impairment. So how does that affect us in the dental office? Well, for one thing, I think that's really, really important is that we may have preconceived views that seniors, it's hard to instill in seniors, certain types of goals for hygiene and care. And there's just a sense that it's time involved, and even if we put in the time, they just don't get it. Well, most people and most old people are not set in their ways and they really would like to change. And they do wish to learn. And they do get it. The other thing to know about seniors is that they want to be compliant. They want to improve their health. But just as important as all of that, they want to make the dentist happy. So we have a patient, even though they're older and they can have some cognitive issues, if we spend the time, they're going to be wonderful dental patients. So let's peel off one more layer, and I think this is a very, very important layer of a senior that we use daily, and I think it's very, very, very important. And again, without looking at what the numbers are, but if you look at seniors and you look at seniors with balance issues, the ability to hear or to see, those are the patients that are coming into our offices every single day. So what does that mean for us? Well, taking a tumble is more than breaking a bone when you're a senior. It also increases your risk of death tremendously. In 65-year-olds, falls are the #1 cause of death from injury. If we take that one step deeper, 1/4 of seniors who have a hip fracture will die within 6 months. So what does that mean for us in the dental office? First, we need to be thinking ahead before seniors come into our office. Are the floors slippery? What about the rugs? Is there ice outside? The positioning of the chair. If patients are down in the chair, how fast can we move them up? Medications that they're on. Because one of the things that we do not want is we don't want our older patients to fall, knowing that's something that we would have a lot of control over and we can prevent. But the other half of this story, and it's just as important as the patients that are entering our offices, is that our treatment for seniors continue till they get home and they're safe. When patients leave our office, first of all, when they enter our office for many dental appointments, many seniors will tell you that they don't eat and they don't drink fluids because they don't want their teeth dirty when they see us. So what happens is that these people can be at risk, so we need great follow-up care. So this next slide is my wave in Maine, and I just want to quickly show you it because it's the real deal. It's what's happening here, and I'm sure it's what's happening across the country. But if you look at in Maine, let's blow that up a little bit. Look what's happening from one part of our state to the other. In 2003, we had 51,000 individuals between 65 and 69. In 2028, they're going to double. They double all the way across the board for us. What that really means is that we have so many more seniors that are entering and are stressing our healthcare system. But just as importantly, in many parts of Maine, we have the aged that are actually caring for the aged. This is Frances. So this is a patient of mine who's 81 years old. She moved to another location, so she's 3 or 4 hours where I am now. And she has medicine for arthritis and hypertension that cause dry mouth and a bad taste. And when I talked with her, so she's not in the area anymore, she said, you know, the dentist up here tells me that my teeth are healthy, and I just had a filling that was $250. Well, and her issue was she does not have the financial access for care. She's also very embarrassed asking her grandchildren to go back and take her to the dentist to fix very, very unattractive teeth. And that is a story that we hear quite often. So this is Millie's finances, and it's the finances of many seniors over the age of 65. Their median income is $15,000. So what does that mean? A couple of things. One, if you were breaking out $15,000 into what it costs for rent, let's say it's $800 a month in Maine. That could be, say, $9,000 plus a year. Food, heat, medicine. One of the things that will happen to seniors, now that they're not in the working world, the first thing that they give up is they'll switch out their regimes on medication. So if you're their physician, or you prescribe them medicine and it's 4 times a day, they may take it once a day to stretch it out, or they may take it every other day. But one of the other important parts of income in related to teeth and a lack of teeth is that if you make $15,000 or less, the chance that you will be a dentulous, no teeth, is about 45%. On the other hand, if you make $50,000 or more, the chance of being a dentulous is 4% to 5%. A tremendous difference just based on income. And I think this is just important to realize that, again, most of the seniors that come into our offices, 70% do not have health insurance, dental insurance. So this is Frances, and this is her husband, Walter. So we just talked about Frances, and she's in a dilemma. So she does not have a lot of income, disposable income for her dental work. So she has some options. Does she go in and have her teeth fixed? Does she take them out? Or does she opt for no treatment? Now, she has a next door neighbor, Joe, who has always counseled her to do what he does. Go to the emergency room. So in Maine, we have 30 to 40,000 visits to the emergency room for dental treatment and dental issues. Now, in Maine, Medicare does not cover any dental treatment. So dental treatment that people opt to have comes out of their pocket. So many times people will use the emergency room as their primary care dentist. So you have somebody accessing the healthcare system, using the facilities and billing the system $700 to $1,200 for a dental emergency. We also know that if they go once, they many times will be at the emergency room 4 times over the course of the year. So she has a dilemma. Does she get them out? And her husband, who's in long-term care, it's also a situation because she has to decide what is the value of having her husband have teeth. Is he safer not having the teeth? So this is the menu that Frances would see essentially going into the dental offices. And, you know, it's a dilemma where she spends her entire life believing that she can save her teeth, and she works hard to save her teeth. She gets the fillings done, she comes in for the cleanings, and after 65, she has that financial access dilemma. So I am now going to be talking about some of the trends in dentistry. I apologize, you have recognition twice. One should be prevention, and the other should be recognition. And then looking at some chronic diseases and how that affects the oral health of the patients that you see. But the first item that I would like to take a look at is an article in March of the American Dental Association by Marco Vachusek, who spoke at your convention in San Diego. And I think for lots of reasons, this slide is such an important slide for all of us and for what we do. First of all, Marco Vachusek is the chief economist for the ADA. And secondly, he is the vice president of the Health Policy Institute for the American Dental Association. So some of his comments, I think, show us where we are and where we need to go. First, we will not see major expansion in dental care use of oral health in the coming years, especially among those who need it the most. Secondly, affordability is the greatest reason that seniors avoid care. The third, and this is something that I think we all hear quite frequently, is that the idea that dental care can be stimulated by convincing seniors that it's worth it is a complete fantasy. And if you look at Frances and Walter, they realize that it's worth it. They just can't afford it. And the last, I think, is key for us in integrated systems, that seniors tend to do not perceive the need for care and may not perceive the need for care. So it's very important to have an interprofessional approach to care, their access points. So Millie, Frances may not be able to afford to come into the dental office, but she can afford to go to her medical office. So it is really important that when she's in a medical facility, that she starts to get some direction on what she needs for care. If they perceive the need, seniors will tend to come back and do the best they can to get dental treatment. Well, in 1988, it's been a long journey of integrating oral care into oral health care. So Dr. Krupp really wanted to make an effort to have oral health as being integral to total health care, and also to have a qualified workforce. We changed designs in curriculum and the way we educate our professionals, and also to really strive to reduce the wide disparities among different populations. So if we do a report card on ourselves, we can take a look at, well, we have made progress in individual and community oral disease prevention and promotion, health promotion. We've also increased our knowledge about dentistry, ways to prevent and to treat healthcare problems. But where we have failed, and we have failed this increasing population of seniors, is that the reduction of disparities has been at most minimal. And we have also failed at educating our non-dental practitioners about the importance of oral health. So patients of mine that may have come into the office in the 70s and 80s, they believed what we had to tell them. They could keep their teeth, they could get their smiles back, and they can function. And they worked really hard and believed the medical and dental profession that it was possible to have a lifetime with your teeth. But what happens after they hit the age of 65? They were very compliant and had their dental visits to take care of their care. And now they are in a situation where they could not continue with their dental treatment. And so we would see breakdown. On this trend in oral health care, I only want to really look at the top two, edentulous rates and caries. Well, edentulous really has decreased since 1999. But I want to go back to the median income. If you have an income of less than $15,000 per year, that hasn't affected you. Your edentulous rate is the same, if not higher. So when we look at edentulous rate, we want to look at it is definitely based on income and financial access. The reason that you'll see that as more caries have increased, it's only that we're saving more teeth and that more teeth are exposed to disease. Pam is a person who, when she goes in to see her medical team or dental team, we are definitely influenced by ageism, because many times people will dismiss treatable disease as just the pathology of old age. It's just, we're going to get it because we get older. And we fight this every single day. And I think that we fight that in the healthcare system, in our dental community, and in the medical community. Now, if we look at, when I do a survey of the medical fellows in geriatrics and internal medicine, family practice, I will often ask them, how many hours of education did you get in the last 5 years on oral health? Well, this is just a survey from the Journal of Dental Education. Most will say less than 3 hours of oral health. And I will typically follow up with, where did you get most of your training in oral health? And universally, they will all say the same thing, from my hygienist. So we haven't integrated it even today where we should. There is plans on the horizon, and I hear more of the possibilities today than I've had in the past. But still, it's important to realize so many still are not aware of the connections of oral health. when I talk to physicians, the two most common questions that I get, if they haven't had a basis of oral health, what is a cavity and what is gum disease? This next slide is probably one of the most important slides for me personally. I was asked to talk at a convention of geriatricians, internists, family practice docs, and it was 8 o'clock on a Saturday morning, and I was to talk somewhere between a coffee and a croissant. And I wanted something that would keep my audience awake. So when I looked at my audience, these are the slides that I put up. And again, the numbers mean nothing. But what I wanted to do after I got these slides up on the biggest screen that I could find, I looked at the audience, and typically if there are dental issues, there's a referral to a dentist. But my question to them was, which one of these diseases, if it was on your patient's forehead or on someone in your family's face, which one wouldn't you treat? The second question that I asked them is, which one of these diseases would not affect attitude or the ability to thrive? From this slide, a number of projects were developed to re-educate physicians at their own request. So this portion of integration into the healthcare team, similar to the FQHCs, is so vitally important. Ultimately, what are their impacts? What are their oral impacts? If you had a patient medically or dentally that came into your office and said they had a less satisfying life, embarrassment, avoid foods, and had pain, I know that most of us would take a step back and say, yeah, sit down, let's talk about that. But so the oral aspects directly affect the medical well-being of our patients. You know, I love the saying of one of our dean at Harvard, Dr. Donoff, is, I'm not sure where the separation was when we took the mouth out of the body, but it's time to put it back into the body. And instead of having two healths, where there's a dental health and a medical health, it's time that we have one health. The other thing that we want to take a look at, and I think this is very, very important, is we know that the oral impact but now let's look at how the oral impact can affect health issues. Now, this information on this slide comes from insurance data. So the insurance companies were looking at what can make our bottom line better, essentially. What can reduce the cost of disease? So this information here is from the American Journal of Preventive Medicine in 2014. And essentially what it says is, without getting into, again, numbers, is that treating gum disease can lower annual medical costs for many chronic conditions. Also, treating gum disease can reduce hospital admissions by the percents that are shown there. So now we have a tie-in of, we can make a difference not only health-wise, but financially, for these services. I want to take another look at one more layer of that onion. And that's when you have a patient that's over 65 and is coming into your clinics or in your offices, 80% have at least one chronic disease. 75% will have at least 3 or more chronic diseases. Now, we have already talked about the fact that when you manage many of these diseases with medication, and we've already talked about, without separating the medications into one versus the other, almost assume that most medications will cause oral issues and potentially oral disease. Just as a quick scan of the population, you can see that we have a real buffet of certain diseases that affect our seniors. And usually it's medication, but it's also how do we deal with them in the chair. But as importantly as what I had stated in a couple of slides back, it's not only their presence in the chair, but we need to follow these patients when they go home. Are they so sore that they can't eat? Because seniors get into crisis so quickly because they can dehydrate fast and they go downhill very quickly. As we age, we lose our thirst mechanism that triggers the ability to say, I need to have a drink. So when we look at seniors, they may not rehydrate themselves because they're not getting the message, I need fluids like you do when you're 20 years old. So they get into crisis. We need to follow these patients carefully. I apologize for the moist chronic diseases at the top. This is the most chronic diseases associated with medications. 2/3 of those seniors take one medication. At hospital discharge, 6 or more, nursing homes, 12 to 15. Again, the numbers aren't that important, but what is important is to realize is that these drugs will definitely affect the oral environment. Quick questions on saliva. Does saliva input diminish as we age? Not really. So if you have a 20-year-old or an 80-year-old, if you have a 20-year-old or an 80-year-old, they're producing similar amounts of saliva. What changes if you stress a senior, he can reduce the amount of saliva dramatically and may not get back full function. This other point that saliva production is the highest in the afternoon and decreases at night is quite important. So if you have a patient who's on medication that has reduced the amount of saliva by 2/3, and you also know that in the evening, most of the saliva shuts way down, the combination of medicine and just the normal rhythm that he's not producing saliva at night kind of gives you an indication you do not want to be giving sugary foods to seniors at the end of the day. And the last, there is the diminished taste of saliva. The reason this is very important for you to be aware of with your patients is that with diminished taste, the very first thing that they will increase is sugar and salt. My father is a great example. He always had 2 sugars in his coffee. As he aged, as he lost saliva, and he had diminished taste, he increased the salt, and his 2 sugars went to 8. So let's just have a visual of saliva. So if you're 20 years old or 80 years old, you're going to have 1.2, 1.5 liters of saliva that's produced. If you're a senior and you have medication and it's the end of the day, we just talked about you're not producing very much saliva. Well, we need saliva for taste and swallowing and remineralization and many other functions. So it's important to realize when we have saliva and when we don't. If you have medications, what happens is the amount of saliva that we may have normally during the day may be cut by 2/3. So you have a patient who is much more prone to oral disease, decay, comfort issues, and multiple other series of problems just because of the lack of saliva. So why this is important, knowing that many seniors are not coming into the dental office after the age of 65, but may go to our medical counterparts, it's very important when we give medications to seniors, in the same breath that we give them the medication, we should be saying, these medications are going to cause dry mouth, potential problems. You're not going to have much saliva. We should consider maybe a saliva substitute. If you're really dry, I know that the first thing that you reach for is a lemon drop, which is very bad for your health because it will cause damage. So we want all of that information coming from the first access or contact point. I'm going to skip our friend here, and look at just the focus on the future, on innovative models of care. I do believe that we're going to have our greatest success in reducing and improving oral health in seniors by having integrative models very similar to what NOAA represents, and having a team approach where seniors can be looked at both medically and dentally, and that it's a collaborative, that we're working together, and we're both educated on how what we do affects the other discipline is just so important for the future of seniors. The other portion of that is to get some type of Medicare coverage for seniors to be able to provide care. But as one of those slides I showed you previously, it's not only to provide care dentally, but if you provide care dentally, it improves the medical model of care. And I think we just talked about the importance of medical and dental integration to improve oral health. So I think this is the future. And I believe this is what a lot of the QHCs work with and do well. They are a collaborative where people work with one another, and they also integrate into these facilities and into the community the ability to work, within as part of primary care and vice versa. And with seniors, because access is such a problem, and all the access issues are such a problem, it's wonderful to be able to go into a facility and to be looked at without making multiple visits, and to be able to have a team that can discuss treatment and develop a treatment plan. And this follows just what I had just mentioned, that when we look at seniors going into physician offices, the graph on the left really is just pointing out that when seniors will go in for a physician visit, many have no dental visits covered. So you have seniors that can make it to their physician's visit, and unless they realize the importance of seeing their dentist, and it's actually discussed by their primary care docs, they may not get back to the dental office. It has been shown that if the perception of need is there, they are more apt to go back to see their dental professionals for care. In an integrative model, it may be just walking down the hall, but this is very important. Vice versa, it's also true where with dental visits, there's a certain percent that will have no physician visits. So as in the dental component, we can be a great referral source back to our collaborative partners, the physicians. So in the FQHCs, these health centers that I have been in are really patient-oriented. They serve populations with limited access to health care. And in my world, when I look at seniors, these FQHCs are really some of the champions of care for our senior population. And it is one of those models that certainly give that wave that we talked about earlier hope. I'm going to skip some of these other the other examples. I just want to mention quickly that when we look at disabilities, another layer that we have to be conscious of is that 50% of the seniors have at least one physical disability, and they increase with age. If that disability if the ADL is something that affects a patient's ability to eat, that is a great correlation that they also will have a difficult time with their oral health. These next two slides to me are, I think, so important, and it's something that I deal with every day when I go into long-term care. And it's about rows, and when typically we think of issues, it's medical, not being able to brush their teeth, but the results of these and how patients look at themselves is very important to look at. So I'm going to read the last paragraph is that with her poor appearance and discolored broken teeth and smelly breath, she has stopped all social interactions. One of the things that will happen with seniors if they're not happy with their appearance and they're afraid of their bad breath, they become socially isolated because they do not like their body image. They will pull themselves out of community. The other thing that you will find is that they stop communicating because they do not want to open their mouths to communicate. Most studies will show that two of the most valuable assets for seniors, two, are appearance and the ability to chew. If you have a good appearance, you will socialize. And what also the other great joys for many seniors is the ability to eat. And both those will increase the quality of life. So I'm just going to quickly go through a couple of these 10 most common. A lot of these we've already covered. The number one question I get generally from everyone, even though it may not be asked the same way, is this normal? Am I just destined to fall apart because it's a normal part of aging? And we know that it's not. I just talked about the oral health and body image and social interaction. For me personally, two of the greatest problems that we face with seniors, that they do not like the way they look and they pull themselves out of community. We've already talked about probably my greatest beef is the dentist believes that we are the only healthcare professionals willing to look into someone's mouth. A lot of these we have already answered also. Is sugar-free candy better than regular candy? Now, all of these questions came from seniors. Came in the other three. Well, sugar-free candy, obviously, from our standpoint, is better than anything that will produce acid, and that can cause a harmful disease. So, yes, sugar-free candy, absolutely. I will tell patients that are caught in some type of assisted living or have any cognitive impairment, just remember that sugar-free candy, and xylitol as an example, can cause explosive diarrhea if somebody is going through an entire bag of sugar-free candy. We have already talked a little bit about the second one, any harm in eating before bedtime. We do know drugs will decrease saliva. In the normal body rhythms, there's less saliva that's produced before bedtime. So absolutely, if they're going to eat before bedtime, we need to remanage that care. Common question, will chemotherapy affect my oral health? Yes. Anything that will affect the production of saliva will definitely affect health, tissues, soft tissues, and hard tissues. Fourth question was, my medications make me so dry that I cannot swallow. What can I do? Well, what I'm hoping is, what answers this question is that when they're in the medical portion of our community and they're handed the medications, when they're handed the medications, they're told this could cause dry mouth. So what you need to do is pick up a saliva substitute. Knowing that you don't have a lot of saliva, you need to be careful on what type of candies that you use. You want to go sugar-free. And so you want to be sure that that initial point of contact doesn't always have to come from the dental office, because we already know from the financial access issues, that many patients will not make it to the dental office if they do not have the finances to do it. Do saliva substitutes work? Yes, they're wonderful. My doctor prescribed Messi for yeast infection in my mouth. Any recommendations? Yes. So besides being compliant to make sure they use their medicine properly, if you have a denture, you want to be sure that you treat the denture and the mouth. If not, every time you put your denture back in, you'll reinfect yourself. You also want to treat your toothbrushes and throw them out and get another one. Another question that's typically asked, I am a smoker and I drink 3 glasses of wine every day. Any risk of oral cancer? Yes, and it increases. Typically what I'll say to a patient, if it looks patriotic, it should be checked. If something looks red, white, or blue, and it's been in your mouth for over 2 weeks, then get it checked. Seniors seem to be able to visualize the flag, and that's a good, it's a good visual for them to come into the dental office. Another question that I typically get asked, well, is fluoride still effective in seniors? Wonderful. So as part of their treatment, absolutely, fluoride treatments in seniors, whether it's a varnish or toothpaste, can really make a difference in their care. Should I buy an electric toothbrush? Are they better than a manual toothbrush? Love electric toothbrushes, and I would love to have seniors use their electric toothbrushes. In nursing facilities, I'm cautious if they haven't had care on their posterior teeth and there's a lot of bleeding. I like to do a more general therapy and then build them up to something that may be like an electric toothbrush. And this other question in terms of adaptive dental equipment, there's a whole line of equipment that patients can purchase that will aid to their dental health. So I have 10 minutes left. So instead of going on to sort of the next page here, if there are questions, why don't we spend 10, 15 minutes dealing with questions, if you have any?
Yeah, so Dr. Brennan, Candace, go ahead and submit those questions to Dr. Brennan, please.
Sure, we had a couple. So the first question is, can you get dry mouth after years of taking medication, or does it start right away?
You can get dry mouth as we age. So our system ages so that you can get dry mouth after you take certain types of medication. As we age, and the ability to metabolize drugs can also change, so it can change as we get older. So absolutely. So it's really important as we start to get some of these issues that we pull together our team. We want to make sure that we talk to our dentists or hygienists, our nurse practitioners to see what we would do. And I'm not saying we take people off all the medications that they're taking, but there may be a possibility of changing certain medications that may cause dry mouth. Now, dry mouth doesn't, when we say xerostomia or dry mouth, that is sort of subjective. We're asking the patient, do you feel dry? But we also have the ability to measure the amount of saliva. So it definitely can change as we age. There are lots of ways of dealing with it. But the first is just being aware of that you have it, and it actually can, we can change it.
Great, thank you. And another question are, how many states offer Medicare Advantage plans that provide levels of dental services?
Well, I think most of the states do. We have, I don't have the number, but I can get that for you. And the problem that I see in Maine with a lot of these Medicare Advantage plans, you're still priced out financially. That group that really needs the care really have a difficult time getting some of these programs. And I say in Maine, a lot of the programs that I'm working on now are based strictly on prevention, because I know that if we can prevent dental disease like we did in children, in seniors, we do not have to keep this population cavity free for the same amount of time. So our success rate should be higher. And that's why I really focus on the point access of care. But I can get you that. I just don't have it off the top of my head.
Great. How are you planning to utilize dental therapists in the effort to integrate care of the elderly in Maine?
So that is a great question, because a couple of years ago when dental therapists first came up, it wasn't emotional. It was, what roles do people have? And the next step on that really came back on, well, the first goal is whatever works for patient and patient safety. I personally think there's great roles for having assistance with care. And one of the problems that we face with therapists and dentists and other healthcare professionals, that in the areas of the state of Maine that really need care, it's difficult to get professionals there, because we all kind of face the same bills from education, so it's hard to get set up from a financial aspect. So everyone still tends to group into the city or around cities. Looking at the data from Minnesota and New Zealand and others, it's been very successful. It's worked well.
Okay. Are there any medical schools out there that are providing more up-to-date oral health care recommendations for seniors within their curriculum?
Well, it is one of the, yes, the answer is absolutely yes. Harvard is and Tufts and some of the schools in the Boston area and across the country are looking at oral health not as a separate part of medical care, but are actually putting it into the medical and dental curriculums. So we're starting to see more of it. What I like about the way it's being introduced, it's not a separate course where we're just dealing only with senior health. What's happening is you integrate it, when you're studying medications and drugs, we integrate it into every piece of the curriculum. So we are seeing more of it, but we really have not seen enough. And we're still at the very, very beginning of making a real impact on seniors. And essentially, as medical students and NP students and OT students, I want to see this type of education personally, and nurse practitioners and all the different therapists, so that we look at care as a team, and it's everyone's responsibility to take care of a senior.
Okay, great. So there are a few more questions, but what we'll do is we'll send those directly to you, Dr. Brennan, and then you can email them as far as answering those questions directly. And I'll go ahead and pass it back over to Deb to finish us off.
Thanks so much, Candace, and thank you, Dr. Brennan. It was a very informative presentation today. As a reminder to participants, a copy of this presentation and the link for the survey will be emailed to everyone today. The presentation should also be posted sometime later this week to the NOAA webpage. And remember, if you are requesting CVEs, to return your survey to us no later than Friday, April 3rd. It usually takes between 2 and 4 weeks to process those requests. So submit that as soon as you can, but certainly the deadline is close of business Friday, April 6th. This now concludes today's call. We again thank Dr. Brennan for his time. We hope everyone has a great rest of their week.
No.